Okay? This muscle structure comes up to the TMJ here. It pulls out this bone structure under here, which is tied in directly to the sphenoid bone up here, which is what we call the temple bone. It's right in the temple. And where when you get hit in the temple, it shatters really the whole skull because you're dealing with a one bone structure that goes throughout the entire head. And so this becomes an area where you can knock a person out, right here.
If you look very carefully, inside and outside the skull, you'll find that the sphenoid bone attaches to every single bone in the cranial group as well as most of the bones in the facial group. But it attaches to all of the bones that form the cranial vault or your brain case and a good bit of the bones in the face.
And it's tied in, as Doug pointed out yesterday, all of the muscle systems, which can be anywhere from 22 to 26. And that will vary because of the genetics of the individual. And so the sphenoid bone here is a very important one. So when you're pressing on this bone here inward, it torques the sphenoid bone throughout the entire body. And if you are allowing yourself to resist pain, then these muscles again, which are tied in on the lateral pterygoid plate of the sphenoid bone. Now remember, one of them will be inserted here and the other will be inserted here, and they go right up into the TMJ. See? You got one muscle moving this way, one muscle moving this way, and this particular area then, these muscles are going to be in spasm. And so when they get in spasm, it shortens the distance between the TMJ and this lateral pterygoid plate, pulling this out, pulling this in, so that you have a very indented temple. Have you ever seen people come out of a slave labor camp or a prison for after many years? The hollows of the head are way in. And how are the eyes? They're very gaunt. They're pushed clear back in, and they're sunken. The eyes are sunken. The foreheads are sunken. And this is all due to the sphenoid activity.
And the suppressed pain in particular.
Now, that is due to your suppressed pain, because the suppressed pain will find itself in this particular pterygoideus medialis and pterygoideus lateralis muscle, which again are these two muscles that you see here, so you can get that clearly in your mind. It's going to be this one right here and this one right here. And these are the ones that will be moving when we start working with it. I'm going to mention this now, get this now, and you'll relate to it later, because when we go in on that triple axis positioning, we start and we cannot get past the spasm on what we call the pterygoideus lateralis muscle. And this will already be in spasm. And so we have to work with that until we get the pain released from that, so that muscle spasm will relax. So the pterygoideus muscle, shall we say, so the lateral plate of the pterygoid, of the sphenoid bone, will start moving back in the head, pushing out the temple bone here, pushing out the orbit of the eye here, and you'll find that the eyes will move out markedly. And I think that some of you already had that happen to you when you had just your tailbone worked on, is that the eyes came out and the forehead right in this area came out. In Sid's case, the cheekbones came clear out this way. And it made a rounder head rather than a very narrow head. Now, did Kath see that, Sid? She understood that. A little surprise to her, wasn't it? Now we have half-inch taller. Oh, that's good. Sometimes. You can't work on small cars now. Okay, so anyway, this is the area. Now that is your suppressed pain. So when we're dealing with pain, we're dealing with the pituitary gland. And the pituitary gland, Doug, would you get the cranium for me? Where did Anita go? Still going around with that? Have you got everybody? Okay, Doug, would you do me the favor of showing everyone where the pituitary gland is? In the turcus sullica, which is right in the middle of your, right in the middle of your sphenoid bone. So whenever there is pain, it's going to affect the sphenoid, which is in turn going to affect and put the squeeze on the pituitary. And so oftentimes if you have a pituitary problem with lots of migraine headaches, which we talked about, tied into the thyroid, if you remember, we talked about how a low thyroxine output can affect the pituitary. All of this will be all tied together here for you. So you're going to deal now then with the pain factors related to the pterygoideus medialis and the pterygoideus lateralis. The pterygoideus lateralis being the lower of the two. And they're both tied into the TMJ. And you'll find that when we get that taken care of, oftentimes the cracking jaw or the TMJ problems, that the medical people or the dental people use a lot of these splints, they put in the mouth for the TMJ problems. Using cranial electronics, there's no need for these splints that you put in your mouth to control your TMJ. Lil.
My dentist has been trying to talk me into having my teeth ground down to cure this problem. Can you comment on that? I've always resisted it very strongly.
If your jawbone is already crooked, then why add insult to the injury by grinding the teeth down? Let's just pull the pain out of the bone structures. Everything comes back into a symmetry, and then the teeth will not have to be ground down to make a symmetrical jaw out of something which is already asymmetrical. Okay? Now this is how the dentists solve it, because now we've trained a lot of dentists in cranial electronics, and they've had wonderful results in it, but they don't use it because it takes too much time and they can't make enough money. That's the problem that we've got. Because when you're doing a cranial, it's going to take 2 or 3 days sometimes on an individual. It doesn't make it very productive as far as money is concerned, because people cannot afford that type of long-distance treatment. Please consider that. So oftentimes this type of work for you, for me, becomes a labor of love. And what I do is, in the Cook Islands, what I do is I take people and I take them and train them in cranial work when a person is ready for it. And I'll have a series of tables set up, which are nothing more than mats on the ground and sometimes a little bit of a very small pad. And we just go do cranial work right then and there. Right, John? And the cranial work gets done. And the people get their heads perfectly symmetrical, with many of their asymmetrical problems, TMJ problems, completely gone. And I let the families work on families. And this has become something that works quite well as far as I'm concerned. Now, after we get through the pterygoideus muscle, do you see where the pituitary gland is, by the way? Y'all getting that? Who didn't get it yet? Okay, we're moving. The next muscle structure that I want to talk to you about is the masseter muscle. And the masseter muscle is virtually going to be attached to the zygomatic arch up under here. And we're going to put the finger, which I'll explain in a few minutes, in a position where you're going to deal directly with the masseter muscle. And that's the one like the old bulldog, he chomps his jaws together and doesn't let go. That's the muscle in here. When you just take your jawbone and clench it together, you can find that masseter muscle in here. It pulls the lower part, the lower jawbone up, so that you can clench your jaw. Now, the masseter muscle will be directly related to the pineal gland. The pineal gland is the one that is going to respond to enthusiasm. So if you have suppressed enthusiasm, which we mentioned the first week. You're going to have a calcification in the pineal gland. And that calcification then in that pineal gland will shut down the pancreas, shut down the pineal, and therefore the masseter, which is reflex to the pineal gland, will become weakened in its ability to chew food. Now, there are two things that show that the body is becoming ill and is starting to fall apart. Number one, the inability to chew, and number two, the inability to swallow. You will take an individual who's taking a few capsules and pills, and if they're quite ill, it's very difficult for them to take down even one at a time. As they start getting better and start feeling better, then they can take down more than one at a time, like two at a time. And then after a while, you can take a whole handful and take them down with no trouble whatsoever, because the ability to swallow is returned. Now, the esophagus, or the ability to swallow, will be tied into the heart and reflex to a number of different areas. But one thing we want to look at is the chewing work that we do and the swallowing. Now, let's now concentrate on chewing and the necessity for chewing for stimulating the cerebral spinal fluid. Doug, would you take the ball here on that?
Well, basically, it's pretty straightforward. If you just kind of put your hands up on the side of your head like this and chew, you should be able to feel a certain degree of mobility there in the skull. And one of the things to realize is that chewing is a very, very important physiological process for any number of reasons. But if we're looking at it in terms of the cranial structure and function, the chewing is one of the prime things that's going to keep the sutures open. And when you start to, one of the things that John and I have seen over the years with a number of people, and this goes back to some of the questions on fasting that we had about 3 weeks ago, is if you take individuals that go on prolonged fasts, whether it's a juice fast or a water fast, but basically just something where there's not any chewing going on, one of the things that you'll start to see, and you'll see this within a month or thereabouts, is you'll start to see the head really start to collapse in. You'll start to see the temples cave in because of all the suppressed pain related to the pterygoids, but you'll also see a lot of locking up of the sutures. And you'll find that particularly in individuals that have done years and years and years of fasting, where this has been their major form of therapy, you'll have a very, very calcified cranium with little or no mobility there, because the chewing is of great importance just in keeping all of that open.
My colon therapist is the one that got me into the juice fast, and she insists on you chewing your juice.
You can chew the juice all you want, but it's still not the same thing as chewing something with fiber. I mean, I agree that chewing the juice would be helpful, but it's no substitute for chewing something that actually needs chewing. And I don't believe it's going to be enough to keep. I may be incorrect in this, but I don't believe that there's any way chewing juice is going to be enough to keep your sutures open. It's no substitute for the real chewing. I might add, by the way, on another level, that the chewing is very, very important because something that we'll look into in the next couple weeks, you have reflex activity from the various teeth to different organs and glands. And so if you have all your teeth, which very few people have, all 32 teeth in their head, but when you chew and mechanical pressure is exerted along the meridians for the different teeth, this is very, very beneficial and really necessary for the proper health of all the corresponding organs and glands and muscle structures in the body. So there's a lot of other benefits to chewing above and beyond the cranial function. One thing I might add is that cranial deformity, the thing about it, like, for example, in iridology, some people would say, well, what's a good eye look like? And, John would say, well, he's never really seen one. The thing to realize is that's largely true with the skull as well. We haven't really seen very many good skulls because, well, probably next to none, I would say, pretty much none. About the only place that you're really going to see a halfway decent skull is if you get out into a real isolated population group where they've remained on a fairly natural diet for many generations. And in places like that, you'll find, first of all, it's a sure sign that you have a lot of cranial deformity if your teeth are not perfectly straight and if there's not room for all 32 adult teeth. So right off the bat, how many people here have all 32 teeth in their head, including their wisdom teeth? Okay, well that's basically my point. You know right off the bat that you've got cranial deformity. I'm surprised to see that many, actually. You know right off the bat you've got problems if you don't have room for all your teeth, or if your teeth are coming in all crooked and bent around and so forth. That in and of itself is a very clear sign of cranial deformity. And you can go to the work of Dr. Weston Price, the same dentist that did the original research on root canals, and he was able to show back in the 20s and 30s that as soon as one or both of the parents shifted away from a natural diet towards processed food, one or both of the parents, as soon as that happened, any children that were conceived after that would be deformed. They would have various levels of cranial deformity. So right off the bat, that pretty much puts all of us here into the category of having deformed skulls. But I think if we look at it on a deeper level, the thing to realize is, even if you go to relatively isolated cultures, of which there aren't too many anymore, but there's still a few, you're still going to have a tremendous amount of cranial deformity because you're also dealing with generations of resistance. So if you want to be more absolute about it, there probably aren't any good skulls anywhere just by the nature of the beast. Just the nature of the resistances that we all have.
So basically then, we're going to be dealing with 4 muscle structures. Now, do you have in front of you page number 18? Page number 18. Would you get number 18 out right in front of you, please? 18. And we're going to go over this one word at a time. This is called the release of the triple axis. Now, the first thing you do, and Doug, could you get the skull here and illustrate this? We press medially. What does the word medially mean? Toward the center of the body, or in this case, on a line toward the center of the head, so to speak. From a lateral position to the side, medially would mean toward the center of the head. Oh, that's all right. No problem.
Yeah, this guy's top nut. Okay, this top nut's staying on very good.
Yassel had too much of a hassle here. Okay. Anyway, you press medially on the lateral posterior portion of the maxilla above the alveolar process. Got it? Okay. Now, Doug is going to show you where the finger's going to be. And you're above the teeth line here, John. Above the teeth. Take your right finger, okay, your first finger on your right hand, and you move in above the teeth line on the left side of the body here, of the cranial. You're above the teeth line, okay? So you're pressing in toward the gum line with this portion of your finger. Okay. Now that's the first muscle. That's the origin of the buccinator muscle. You ever see a guy play the tuba? And he's got his mouth all puckered up. like that. That's the buccinator muscle, and that is often considered to be a reflex to the thymus gland and a reflex to the immune system. And so some people believe that in body electronics that by exercising the buccinator muscle, you're also increasing the immune system. So this is something to consider. So,
and the thymus, of course, reflexes to the emotion of fear, which seems kind of interesting because that's usually where most people start at the beginning of a cranial, especially if they've had one before.
Yeah, and like playing a tuba. When you're dealing with playing a tuba and you're putting pressure on these muscles, so on, you are actually doing a lot of breathing to do that properly. So breathing has a great deal to deal with this particular thymus, to deal with fear, and so on. Now, Anita, would you get the other skull? I want you and Doug to go around while I'm explaining all this here. And I want to have you show the first point where you're pressing medially. Now get down under the coronoid process. Okay, now show where the coronoid process is. Right, on everybody. You go around from person to person so they can see it close up. So you press medially on the lateral. Lateral means to the side, John. The lateral posterior, which means the lower portion of that gum line, so to speak, of the maxilla, above the alveolar process, and that's where the teeth are. Now, y'all got that understood on number A on your sheet. Y'all see that? We're going to take our time to get. Can I turn the lights on a bit here? What's that? When you showed it on yourself, that's yeah. But you press inward toward your gum line. You got that? Now, need to take that around, all the way around. Show it to everybody, close up. Now, the B part, on your notes, you got your notes there now? Page 18? Press superiorly. What does superiorly mean? You're pressing upward on what they call the zygomatic process. And that means that you've got your finger right here. You're pressing inward this way and then pressing up against the zygomatic arch right here. So you're pressing upward at the same time you're pressing in this way with the bottom portion of your finger. Okay? So you're pressing now upward with the top of your finger. You got that? Okay, you're pressing superiorly. So you're pressing upward like this. Now put your hand in your mouth. Swish and swallow. Okay. Get it back in here. Press way back. Far as you can go. And then press in this way and then press up that way. That's the two axes. Oh. Hear that sign of contentment.
I notice a lot of you are trying this on yourself. If you're going to start messing around on yourself, start off with the right hand position. Don't try doing it like this. Do it like this.
On the left side.
Use a right finger on the left side or a left finger on the right side, because if you start playing around like this, you're just going to get confused. I mean, put your finger in the same position it's going to be in somebody else's mouth, which is right finger on left side and left finger on right side.
Okay.
Not both at once.
You got that? Okay, now. Is everything all right out there? Okay. Now you got that. The C part. You press laterally on the medial portion of the coronoid process of the mandible, which was the insertion of the temporalis. And here's where you feel your lower jawbone, which will vary, and you're going to have to open it a bit sometimes or move it over to one side so you get your finger under that, because this is going to be the one thing we'll have to work with, and this will be one of the most painful areas. So you're putting your finger in here, pressing this way, and by the fact that your finger is sitting there, you're going to be pressing automatically against the coronoid process of the mandible.
John, a question just came up, so everybody's clear on this. You're doing all of these things all at once. This isn't one after another. You're doing all of these things all at once.
But let's get them right now, one after the other, then we put them all together. Okay, the D part. The C again. If you got your paperwork, press laterally. Which way is lateral? Okay. Laterally would be toward the outside. You're pressing outward. You're pressing outward here. And you're pressing out against this coronoid process right here of the mandible. By the very fact that your finger is back in here pushing this way and pushing up, you're also, by the very fact you're clamped in here with your jawbone. And therefore your finger automatically is against that coronoid process. You got that? Okay, who doesn't have it yet? Lil, we'll pick on you. Now, what don't you understand? You're pressing this way in toward the jaw. Put your finger in there. Okay, take this part of your finger here and push against the mandible. There on the what they call the just above the arch there, alveolar arch. Got it? Now press up this way against the zygomatic process, which will be the insertion of your masseter. Now, by the very fact that you have your finger there and you press it back in, you're going to have this part of your finger is going to be pressed on automatically by the jawbone, coronoid process. You got that? You got that? Okay. Everybody got that? Okay, that's C. Now D is going to be the humdinger, and that's going to get the this is going to get the pain lighted in your soul, because this is where you press back as far as you can go. You press backward here, posteriorly as far as you can go, and then laterally on what they call the lateral pterygoid plate of the sphenoid bone and the pyramidal process of the palatine bone, which is the origin of the pterygoideus, lateralis, and medialis muscle. Now, what did I say? Okay, we're back here. Watch carefully now. I've got my finger here like so. I'm above the teeth line. I'm pressing in. I'm pressing upward, and my finger is going all the way around here to this lateral pterygoid process of the sphenoid bone. Now, there's a very small part of the bone here called the pyramidal process of the palatine bone, which will be directly attached to the very back part of the hard palate. The hard palate is composed of a portion of the maxilla, which is the upper jawbone, and is also a part of the hard palate toward the back of that hard palate, and is tied in here to the pyramidal process right here, which is tied also into what they call the pterygoid, well, it's actually all tied in together, but right back in here you find a little hard spot way back behind the wisdom teeth, which is called the hamulus. And this is a very painful spot. I have not yet found what that is for or what it activates. If you want to play with that on your own, be very careful of it, because we don't want to snap this thing off. Oftentimes that is a result of dental teeth extraction where the hamulus is destroyed at that point of time. That's that little thing right there. That's the hamulus. Now be careful even touching it on the bone structure, because it'll pop right off. It's very fragile. Yours have been popped off. Yep, they're not there. But the hamulus here is, I believe, is a very important little bone structure. I think everything has a place and a purpose, but I do not yet know what this is all about. But I do know that when you press backward on this bone structure, now remember, you've got a balled up spasm in the lateralis and the medialis muscle. So you have to start, you ready? You have to start down here. And so you take your finger and you slosh it really good. If you're doing it with yourself, this is how I found these points, by experimenting on myself during my evening hours of leisure. And by putting my finger back in here one day in West Virginia, all of a sudden my head became bean-shaped, like this. And at that time, the host would usually come by, or the hostess would come by and see if I needed anything in my room. And this time she came knocking at the door, and she looked at me and she said, "Oh my God, what did you do, bump your head?" Because my head was all out like this. And I was working on it very, very quietly, and I thought to myself, well, I can't stop now, because it really looks terrible. When I looked in the mirror, my head at that time, if you remember, I mentioned, was very, very narrow and long. It wasn't a fat head like it is now. Anyway, I kept pressing on this little thing here, and finally that thing started moving. And I felt my finger right in here on this muscle spasm, which I didn't recognize, because I wasn't really familiar with the structure and the spasm and the suppressed pain in the pterygoideus muscle, which would be the pterygoideus lateralis here. And then my finger started moving up. And then this whole bone structure came way back, and my eyes came forward one at a time, and my temples came out one at a time. Now normally when you're working on the left side first, you'll get the motion over here on the right side of the head. And then when you work then on the right side of the head, then you get motion over here on the left side. Now if you have a crossover of nerves, then you'll have both sides working at the same time. So there's not a law there that is full. But this really is a heavy-duty muscle structure to work with. And it is the most important one, where we now deal with the major issue of why we call it the triple axis. Now remember, the one point on the where we're pushing laterally, or shall we say where we have contact laterally to the medial portion of the coronoid process, that is fixed in position. That is reflex to the temporalis muscle. That will be reflex to suppressed anger, which is tied into the thyroid gland by reflex action. Got that? Okay, the other three will be where we place our finger with pressure, and one will be, as pointed out here on the 4 steps, where we first of all press medially on the lateral posterior portion of the maxilla, and that is right on the gum line. And then we push upward on the, what we call the what? Zygomatic arch, and that's where you have the origin of the masseter muscle. And then you have the other one down pressing posteriorly and medially way back on this particular bone structure here. But you start right down in this area, and you gradually move up as the spasm diminishes. Now, you're going to have questions on that until you get in there and start experimenting with the person you're working on. Are there any questions on just the intellectual part of it? Ian, come up here, please. Oh, excuse me.
Okay, how do you know how to move from this one up to the next ones?
You can't get here to start with because the spasm is too much in the way.
You can feel all of the skin pushing you back right in your mouth. Okay.
So you start down here and you just let that soften gradually, and then you just start sliding directly up until it's just right, feels like it's right behind the orbit of the eye, which it is.
Okay, so that tension I felt in my own mouth when I put my finger in there, that resistance is going to subside as you can move up through, right?
That's correct, sir. Okay, and as you look at the cranial, as this is passed around by Doug and by Anita, you'll find out how far that finger will go up there as it's given away. Now, the one danger area will be is when the finger goes absolutely numb, you don't know where it is, and it'll slip back bypassing this particular area. So you have to keep your finger, see how my hand is? It's not like this, it's like this. And then the finger will be curved so that you're going gradually around the gum line and you're coming back and coming in contact with that because your finger's curved. If you keep your finger straight, then you're going to miss that and come back here and feel nothing. You want to feel something on the tip of your finger. It'll be like a little ledge. And that ledge will be well disguised by the muscle spasm, so you feel like there's just a big hunk of muscle there, or skin there, and or mucous membrane there. Now, the next thing on dealing with this, we'll have finger cots to use when we get into the triple axis here. We'll have the finger cots. Keep these clean, okay, and keep your fingernail cut fully off, but not down into the quick, because when you go in there, you don't want to have a whole lot of extra pain. Now, where one of the dangers will be is that when you're putting contact on another surface, when the burning starts, blisters will form. If you're holding that point and you're not lubricating it properly, then those points will become fused to your finger, to your glove, or to your finger cot. It'll become fused there. And I have had circumstances where people didn't follow instructions because they were not paying attention. David Whistler, are you there? Where's David? Okay. Okay. This is important. We want people paying attention and attending class regularly so you know what you're doing. And anyway, as you're working on that particular one spot, you don't want to fuse that finger in there, because when you pull the finger out, the mucous membrane comes with the person. And we usually have one person who's just very, very neglectful and forgetful, and they go to sleep during the cranial, and all of a sudden they take the finger and jerk it out when they wake up, and out comes the mucous membrane with it. Here's where you have to pump the saliva in there on a regular basis and swish it around back there so the thing is always lubricated. And then about every couple of minutes or so, the person who's doing the cranial doesn't leave the point, but they just make sure that the surfaces are mobile and the person is salivating. If a person is going to go through a lot of dental stress or sometimes anesthetic, the mouth becomes cotton dry. At that time, it might be wise to have a little water there to slurp in and to swish around to keep the surfaces mobile so that you don't have this particular problem arise. Are there any questions so far?
One thing that a lot of people have done that's very helpful is you get a very, very small amount of say, flax oil, very, very small amount, and just do like a light coating on the finger that's doing the triple axis, and also a light coating basically where the finger is going to be going, and that can make quite a lot of difference.
The same thing with aloe vera. Some people like to use a little olive oil. Some people like the aloe vera. Some people use the flax oil.
Louis? Yeah, the skin zymes work very well. I don't know if there'll be enough to go around, but that does work very, very well. How many people have bottles of skin zymes? Okay, we got about 4 or 5 bottles of skin zymes. Those are jars. That's very good stuff for this.
That is your papaya material, and it works very, very good for healing of mucous membrane.
Little dab will do you.
Yeah, the papaya salve. Now, are there any questions so far? Kyle, anything you want to say, sir? Bob, anything you want to say, sir? Bob? Anything you want to say? Okay. Now, some of you, Andre, anything you would like to say? Okay. I hope we've covered that part. The best thing to do is to get in and do it. And, pardon me? Yes, come up here, sir.
The only thing I'd like to say is that with that triple axis technique, some people are very sensitive to the intense pain, so I think it's advisable when you first start off not to get over enthusiastic with exerting enormous pressure.
Absolutely.
Because otherwise there'll be enormous resistance and it's going to slow the whole process up. So probably it's good just to go easy, then gradually increase the pressure, and then sometimes you might have to ease off just a little bit and then go deeper in again that way, and you'll find that you'll be able to come up through that point where the resistance is much faster.
Thank you, sir.
You got to be gentle and relentless.
What has helped me the second time, the first time, like I said before, I was resisting the pain. So the second time, I was visualizing that the muscles were opening up. I was like opening that I invited the finger in, not resisting the pressure. And it's like working together, giving a sign when it's too much or when you can handle more. Because you need to keep up the pressure. Like his person said before me, like you can't just hold there, oh, it's going to disappear, it's going to disappear. There needs to be a gentle pressure. But the visualization and the opening up and visualizing the violet flame, even what Esther was doing, we laughed with it afterwards. She had a violet finger going through my mouth. So, and it helps all this.
Thank you.
One thing Janine's pointing out here as well is when you get to the back there on the lateral pterygoid plate, there's not just one spot that'll be sore. There's a lot of different individual spots when your finger finally gets to the back. And if you really want to be quite thorough with the cranial, don't be in a hurry to get done. I mean, don't think just because you hit the sphenoid that everything's all over. There's going to be a lot of different areas there that will be very, very sore and tender, and it's well worth your while if you're trying. I mean, it's not just sphenoid tag here. We're trying to work out all the resistances that are there. And once you're back there, take your time. Don't be in a hurry to get the finger out, but be very, very thorough and go over the whole surface of the lateral pterygoid plate and just really work out all the pain that's in there. Also, in keeping in line with what Andre's pointing out here, there's a real necessity that the two people work, and Janine as well, there's a real necessity that the two people work together and that a relationship of trust, going both directions, be well established there, because if the person giving the cranial is a little bit too frantic about it and a little bit too overzealous and they start pushing too hard, they've lost the trust of that person on the table and they may never get it back. It may be very, very difficult for that to be regained. So it's extremely important when you're giving a cranial to be very, very gentle, go very, very slow. Don't change pressure without letting the person know you're going to do it. Don't all of a sudden just give them a whole bunch more pressure without telling them in advance and making sure they're ready for it and that it's okay. And then when you do change pressure, when you do move the finger in a bit, when you do give more pressure, don't use like sudden jerky movements or rapid acceleration, but be very, very gentle. Don't just like stomp on the gas like when you're driving a car, but just have a real light touch on it and just be very, very gentle about it, because again, it's like once that person stops trusting you, it's going to be very, very difficult for you to ever get that back there during the cranial. On the bright side, when two people really do work together well during a cranial, it's really a very beautiful thing. There's a certain flow that's established between the two people that's quite intimate and really wonderful. And any of you that have had that experience know what I'm talking about, where there's just a real bond formed between the two people. So try to work together instead of you're not working on the person, you're working with the person.
Okay, let's have a seat for a minute, please. We have had in times past, we have people who have quite good egos, well-developed glitches in their computer, and I want to discuss this now with you. You will never receive a blessing from the heavens unless you are willing to allow other people that same blessing and everyone have it before you get yours. Okay? So if you're trying to be the first to get your points held, to get your cranial done, to do this or do that, put that out of your mind. Because we have a lot of people that want to be special. They want to be the best, and they want to be first, and they want to be the center of attention. Now, people who want to be the center of attention, where they want to have people's appreciation, where they want to have people's acceptance, where their focus is on people's recognition, where you are, where you're dealing with what we call the being special. That's what I'm looking at, the word appreciation. The wanting to be appreciated, wanting to be special in all this business. Put that completely out of your heads, because this is counterproductive to anything pertaining to cranial work. I know some people on the table, and in their heart, they want to make sure that they have a little more screaming than the next guy on the table. Or they want to have evidence publicly that they're having a better healing crisis than everyone else in the room. So they can say, oh, I sure had a good healing crisis. It was the best in the whole room, type of thing. Listen, let's not be concerned about that sort of a thing. Now, on the other hand, you have people that hold themselves back and will not allow themselves to have a healing crisis because they don't want to make any noise. They don't want anybody to know what they're going through. Look, people don't need to know what your thoughts are. You don't have to come out and tell people what's going on in your mind. You can be as still as a mouse. But be sure you groan a few times and let those groans out that are associated with all that pain that's in there. Because that is going to be the release of that energy that you're blocking off, that you're unwilling to show the signs of weakness, which is like big boys don't cry or what have you. Be willing to let go. And then once you know you can let go, then experience it on the mental level. And then things start progressing. This is important because Doug will remember on many of VNC class how some people would try to outdo other people, making no individual progress whatsoever, but just wanted to make sure that they would vibrate a little bit more than somebody else, or that they'd go through stuff just a little bit more than somebody else to show that they had a good healing crisis, which they didn't have. It was all show, just to say they were there and did that. Let's stay away from that sort of thing and guard yourselves against trying to be the queen bee or the prima donna, this sort of a thing, because we have a little bit of that here in this room now. And it's just wanting to be the first, wanting to be the best, and put that out of your mind and do everything in your power to be of service to your fellow man first. Okay? I'm so grateful for Anita, because she doesn't give a damn what any other human being on the face of this earth thinks about her. And I've oftentimes champed at the bit a little bit on this one, because she says what she wants to say, and if people don't like it, She has a word for them, but I won't repeat it here. But it's just that, she's going to do what she feels is best and let other people stuff it if they don't like it, right?
Well, people will love or hate you no matter what you do.
Go on.
Go on.
What else should you say?
No, I'm just myself. That's all.
And that's what it is. Now, what bothers me is I find people running around here trying to get approval for what they're doing, or a fear of disapproval of what they're doing. And therefore their entire lives are governed by what other people's opinions are. Hey, when you're on the table getting a cranial now, this is your time. If somebody doesn't like you feeling a little bit irpy and wants the bucket, that's their problem. You follow what I'm saying? It's your time. Don't waste it by being controlled by the possible opinions or disapproval of other people around you. Get down to the business of letting your own stuff come to the fore and work hand in glove, so to speak, with the person that's holding those particular internal points, and just let the chips fall. You don't have to expose yourself with all your memories of all the life on who diddled who and who diddled what. You don't need to worry about those things. We're not the psychiatrist. All we want you to do is to re-experience things lovingly, let them go, and forgive. Right? Okay, you don't have to bring out your dirty linen. But the thing is, look at the word patterns, look at the emotions, and look at the feelings, and look at them and re-experience them on the mental level, that you're free of them forever on the physical level. So there's nothing to fear, because nobody's trying to dig out your dirty garbage. We're not interested in that. And I don't think you're interested in that. You're interested in re-experiencing what comes out. And that's what it boils down to. Nobody really cares how many affairs you had. Nobody cares about who you didn't marry and what you should have done if you had married them. Nobody cares about these things. What we do care about is what we do from this time on in a rational, loving, serviceable type situation to one another. That's all we can ask. Is that clear enough? You want to say something? Doug?
That's good.
Who wants to say something? Who wants to share something from their heart?
Actually, what I wanted to find out, it's not so much say something, how much pressure do you put on with that one finger on the tip?
You give no more pain than the person can lovingly and willingly endure. That's it. And if they say back off and come back in again very, very slowly.
So the object of the exercise is to get as much pressure there as you can with the consent of the person that you are working on.
Starting very slowly, as Andre had pointed out. Okay? And you do it very, very slowly, and move in slowly. You don't do it harshly all at one time and jab the person to death on the first move. It might get your hand cut off. Look, when you have a finger in the mouth there later on, remember the other person has the incisors there. Okay, so you have to be careful. If you do have plates, remove the plates, and we'll work on things without the plates. It makes it a lot simpler. Anita?
Well, that's what I was going to say about dentures and plates. They should take them out, right? Yep. People with dentures and plates, it's easier to work if you take them out.
Get a little bit of Kleenex or a little piece of tissue or something to wrap them up so you can keep them clean, and so on. Doug, what would you like to say here, sir, now?
And bear in mind, after your cranial, it might not fit you again anyways.
Yep. And also, after the cranial is over, you give yourself a little bit of chance to recuperate. Don't try to do everything at one time. Okay. We have been having some strange things happening in this particular seminar that I think we need to discuss to bring you up to date as to exactly what we're seeing. All of a sudden, the last week, and perhaps beginning 2 weeks ago, all of a sudden we start dealing with some very, very heavy pulsing, which continues on for maybe an hour, or in some cases 2 hours, where it's kind of pulsing and in relationship to the burning, and in relationship to just heaps and heaps of electricity. Anna Voss, would you come up forward here and tell us what is happening to you that other people may not be taken off unawares? I think this is a little scary for people if they don't know what's taking place, and I'd like to have Anna explain what's happening to her, and she's not alone in this.
Had a situation with point holding fairly close into the start of the session, where there'd be lots of vibration going through the body, and also electricity coming out. Had some last night and it was just shooting out through the head, and Ken was getting quite a bit of it. But also it happened a few sessions ago as well. But also getting the burning and pulsing or throbbing at the same time. And I've actually experienced that holding people as well, so getting both of those sensations at the same time. But the electricity is quite sharp, actually. I mean, people have been in quite a lot of pain. And it's been a bit difficult for them to stay on the point because of the pain and the electricity just shooting out of the point. Well, last night I was just early into the session, and my whole head started vibrating, and Ken was on the mastoid point, and the head just vibrated at least half an hour, maybe more, and just the vibrations were just there all the time.
How heavy were the vibrations?
They're quite heavy, Ken. Yeah, the head was just, I mean, it was head just going like that, yes.
Ken, would you come up here, please?
It was just continual vibration in the head. My head. His hand.
Yes, Anna's head, and in fact her whole body, but her head, were just shaking like as if she had cold chills, and she had these shooting pains, and it was really, really electric on the thumb. It was quite pulsing, and it was going up. My whole hand was aching, and Christabel was on her tailbone, and she had experienced it right up to her shoulder, that feeling of electricity going through. So it was pretty intense.
Yeah. Christabel had in the chest as well.
Now, I have a question here, Ken. Was the bones actually vibrating like jello, or was she just shaking like she was in a cold chill?
No, her whole body was shaking. I did feel some shifts in the bone, but it was almost like a toothpick breaking, a little click, and there seemed to be some movement like that, but I couldn't feel any jello-ness. But mind you, my hand was pretty numb, so to feel that might have been a little difficult.
There was also trickling down the sutures, and that happened within about 10 minutes, I think, after starting. It was just down this side here. Ken was on the left side. It was just like a little trickle coming right down the suture, very early in the piece.
Okay. Now be aware of these things, folks, and don't get too alarmed when it starts happening. Just stay with it until it ends. But we're getting this pulsing business along with the electricity, along with the heat, and along with this vibration more than we've ever had before in body electronics. That's my awareness of this. Doug, would you like to say anything about that?
It seems like what's happening a lot on a lot of the points is the phenomena have just been changed a lot over the years, and the pulsing seems to be it used to just be that you got a little bit of pulsing at the end of a point, and that was how it was for maybe 10 years. You know, you worked on a point, you went through heat and numbness and all that, and then finally that died away and you got some pulsing, and then that was it. And We started getting a lot of other phenomena maybe around 87 or 88 with a lot of electricity and other things. And it got to the point really where there's not a regular pattern anymore as to what happens in what order. But it does seem to me that there's a lot more pulsing than there ever was. And the other thing that I've noticed progressively over the years is that I think it's actually gotten a lot more painful holding points. I think the amount of electricity and heat that people are getting in their fingers is far more than it was 10 or 15 years ago. And I've noticed that in particular in doing the cranials, that it seems like your finger just really gets fried in doing the triple axes much more than say 10 years ago.
Okay, let's analyze for a few minutes what this pulsing is. The pulsing that you're feeling is roughly at 72 beats per minute. And this pulsing is what we will call, for lack of a better name, the universal life force. This seems to come into the physical body from an external source, and it activates the human body to go into a healing when the resistance of the person who's having their points held is gone. And when that resistance is gone, then you have the reversal of what we will call the vibration of creation, which according to Walter Russell in his vision of shall we say, the creative process, he calls it all creative process is electrical. Now, if you are creating something through resistance, and that is going to be electrical in nature, then when that is uncreated, you will have the reversal of that same electricity, and this is when you have the tremendous amount of change in the physical body as people are holding these points and this electricity is coming out. You take a look at some of the eye color change and pigment change in the body and so on, and this is becoming very, very profound in my estimation, because everything is accelerated now and speeded up, probably more than ever before. Now, with this universal life force, with its pulsing coming into the body, this appears to be the result of more and more lack of resistance to what is happening. So people are becoming more loving, at least the ones who are having their points held. They're becoming less resistant to the pain. They're working with it and transmuting it. And this is bringing the creative process coming back from the creative effort, where it's now going back into the void. And the electrical process will be in reverse order to how it was formed electrically by the resistance of the human mind. Now, I think this is an important thing to understand. Book 3 goes into this. But the Book 3 did not consider, as far as the point holding is concerned, did not consider the increased amount of pulsing that we have been having at this particular seminar. I've never seen it before. Now, the pulsing, if you notice, as that moves, the tailbone just gradually comes back into position, or the skull bones come gradually back into position, where the resistance that was there, holding them genetically out of position, shall we say, it's moving back now to approximate a perfect DNA pattern. If you take a look at the skulls of the people, where the cheekbones are coming up, the temples are coming out, the eyes are coming forward, this is happening to an awful lot of people, and we're getting some very, very profound structural changes. It's not with a lot of flashing lights and sirens going off like we had in years past, where there's just been tremendous phenomena attached with it. We're having a very slow, quiet, but extremely powerful revolution that appears to be taking place in the human mind and its action upon the physical body. Peter, you want to say something, sir? Come up here.
I was holding Gary's pineal points last night. He was having the cranial done at the same time, and they come up Well, there was nothing in the pineals to start with, and then they came up to a blowtorch intensity, and then the pulsing came in. I checked that on the sweep and on the clock up there, and it was round about 69, and that must have gone on for over an hour, and that's the first time I've experienced that. The pulsing stopped and the burning went on. It was pretty late into the session, and it burnt all the time. And then they went instantly cold, and then the pulsing returned, which is the perfect end to a point. And that was the first time I've experienced that.
And when the pulsing returned, what was the...
Well, there was no heat in the point. There was just a nice pulse, and that would be on the 72.
Right at 72.
And
so it went from 69 up to 72.
The point just stopped, bang, that was it. It was cold, and I said to Gary, what went through mentally? He said nothing. So it was purely physical.
Well, we would say it's purely physical, but sometimes what appears nothing is just not obvious because we just deal with it.
But I am aware that the time is speeding up. Not time, but the events is moving much faster, and things are changing because vibration is coming in at the beginning of sessions. Has anyone else experienced that, where the vibration comes in at the beginning of the session?
Yes.
That didn't used to happen, to my knowledge. And pulsing something new to me. So anything causes anything.
That's getting to be the way it is. Okay, Peter, thank you very much, sir. Want to say something about it? Okay. Now let's get on with the aspect of the triple axis where we go in and work very carefully on that lateral pterygoid plate, and we release all that pain that's locked into those muscle structures there. You will find that according to the neurophysiology textbooks and the anatomy, when they go into this in detail, they find that roughly 52% of what we call the homunculus, and the homunculus is an artist's conception basically of the amount of nerve supply that is supplied by different parts of the body, like the hands, the feet, the tongue, and so on. But on this homunculus, showing the representative of the proportional amount of nerve supply that comes from the different parts of the body, 52% of all of the nerve activity originates with the muscles of mastication. So when you're dealing with this triple axis, yes, sir? I don't know if I can do it the same way, but 52% of the nerve activity as represented in the homunculus, which you can study on your own in any good neurophysiology textbook, okay? 52% of that is involved with the muscles of mastication. And here you're dealing with the masseter muscle. Here you are dealing with the pterygoideus lateralis and medialis. Here you're dealing with the temporalis muscle. And here you're dealing with the buccinator muscle. These are the muscles of mastication that we need to be aware of. So when you're dealing with all these four muscle structures on the point holding, you're dealing with 52% of the neural activity in the human body and their interconnections, the whole body. And this has a tremendous implication here because you're affecting everything in the body, either by reflex action or directly. There's no in-between on this. Okay? And so these muscles of mastication, the way we've got that put together, anything can happen. Let me give you a little illustration. Up in the Cook Islands, we had the little lady from Norway was working on Tweeta, was working on Babaji. And Babaji had toes that were kind of clawed over like this. He's just a young fellow. And his toes were kind of clawed over like this. And by doing the cranial work on one side, the left side was done first, all the toes on the left foot opened up and were absolutely normal. Cranial work affecting the bone structure of the toes. Now that got my attention. The right side, of course, did not open up. She went and did the cranial work on the right side, and the right side toes opened up. And it was just a marvelous indication as to how anything can cause anything. Because the function of the cranial will affect every part of the body, and if there's a malfunction in any part of the body, then the final thing from a physiological point of view will be the cranium. So, we find that these muscles of mastication then have an effect upon 52% of the entire neurological function of the body. That's heavy duty when you start thinking about it. So some of you are laying there having your points held, and you're just only dealing here with the temporal bone and the mastoid process, and you're sitting there and your whole body is vibrating for a couple of hours with pain shooting up and down through there, moving from joint to joint, and moving through your head, moving through your old tooth extractions and so on. And you're going through actual tooth extractions with all the pain connected to that, the anesthetic that's being released from the body. That's been locked in there. And one of the things that you have to understand is that eye, ear, nose, and throat problems can all usually be traced back to dental trauma during tooth extractions and different, the silver amalgam filling and so on that is placed in the tooth. Now, these are things that we have recommended to get the silver amalgam fillings out. Some of you have taken quite a bit of time to do that. For my 5 root canals, I've been looking at that for a couple of years now, and I'm going to have mine taken out in April. But, it takes a while for all of us to get around to doing what we have to do. And so this is I understand that because I drag my feet, and we don't want anything to interfere with our itinerary, or our agenda. And so we put things on the back burner because things are going to be a little distressful and painful for us. But they still have to be done. So, I did want to talk about that. Now, another thing I want to discuss here with you. Some of you have problems with deviated septums. Now, if you have deviated septums, we can handle that through the cranial work, and if it is a specific blow to the nose, then we deal with that directly, and that deviated septum will usually correct itself. Now, the deviated septum will be, as you're looking straight on, I don't know what page this is. What page? 35? There we go. The deviated septum, the septum is the bone structures inside the nose. And it, pardon me? Well, the flesh is determined by the bone structure. And it means you can't breathe through your nose, or you can't breathe through one nostril, or your nose is out of joint, so to speak. But it boils down to, as you're looking into Doug, can you get the skull and hold that up and show the only bone in the head which runs up and down and from front to back, perfectly vertical. You find this particular, you can see right down through the nose there, you can see where that vomer is. Now this is the vomer. Now this is what we call a medial wall of the left nasal cavity right here, and the vomer bone sits right on top of the upper palate. So the hard palate, the front of this part in here will be the maxilla. So here's your maxillary bone. The part back in here is the palatine bone, and right above that is the vomer. Now, I hope you all had a chance to examine Karen very carefully, because Karen has this large lump coming down the roof of her mouth. That large lump in the roof of the mouth is where the vomer has come down and has split through the intermaxillary and interpalatine foramen, and that comes down to form what we call the torus palatinus. Now, some of you have a ridge in the roof of your mouth, and that is a minor form of the what we call the torus palatinus. Now, this vomer, when that vomer gets, shall we say, asymmetrical, it will cause a deviated septum to form. And so what we have to do when we get into the palate work, which we're going to get into this morning, the palate then, this whole area begins to go through a change, and the vomer then pushes all these other bones up, and you have nothing but all kinds of crunching or movement. We don't have the crunching like we used to have. We have movement of the bones and shifting of the bones, and this whole area then, through the central portion of the facial structure, all of that begins to shift and move around. And it becomes quite an exciting thing, because who knows how many eons of time genetically have we inherited the facial structures that we have. So this is something to very carefully consider. But the vomer is the area which will be the primary cause of the deviated septum. Now, oftentimes in my surgery training, when I went down to the medical school in Mexico City, I think these guys have a distorted sense of humor. The very first thing they did was threw us all into an auditorium, and we had the place was packed, and with students who are just entering medical school, you know, the surgery aspect of it, and they started throwing films up on the screen, you know, of surgery having to do with correction of deviated symptoms, where they go in and ream out the bone structures, you know, and just carve it out of there. Blood everywhere, spurting here, spurting there, and I'll tell you, the students were passing out right and left. And it was just an amazing thing. But we don't have to go through all of that, because with the deviated septum, we can help take care of that with the body electronics. Now, how many of you have deviated septums where you can only breathe out of one side of your nose at a time? Now, that'll have to be taken care of. If that was due to an injury, through a fight or something like that, that is something separate from the cranial work, and we'll have to do that in addition to the cranial work. Any questions there? Yes, Elizabeth? Grab the... Good morning, Kath. Okay.
If you're unaware of any external injuries, how do you determine how the deviated septum was caused?
Don't worry about it. After the cranial work, we'll see if it's still there.
I knew you'd say that.
Okay? And then we'll go to work on it. Now, one thing I remember, when you do that deviated septum, the person goes back through the re-experiencing of the trauma to the nose. They'll taste the blood. They'll feel the mashing of the bone structures, or however it happened, and they'll have a full memory of those things coming back. So these things are very powerful and create a tremendous trauma on the body. And by reflex action, you can have all sorts of problems. Now, do you all see where that vomer is? Okay. Now, that's the first thing we want to look at. Okay, the next thing we want to take a look at will be this particular sheet. This is the bony palate and the alveolar arch. You got that somewhere. What number is that? Okay. There's, on some of your sheets, you do not have certain markings. There is a palate. This is the hard palate, the bony palate of the upper of the upper jawbone called the maxilla. Right up here behind the two front teeth on the top is what they call the incisive foramen. That is where a nerve comes through. It's a very painful place. It is one of the points that we use for the body electronics in the cranial work. Now you'll have between the left and the right portions of the maxilla, you'll have what they call the intermaxillary suture. Now that'll continue on through the cruciate suture to what we call the interpalatine suture. Now, across this way, this is not labeled on some of your material that is handed out to you. So you take this in. This is called the maxillopalatine suture coming across this way. And this is an important one because the landmarks here are extremely important. Over the years, we have found certain key points which have tremendous impact on the palate work that we're doing. One point will be here you're looking at this palate, and one will be here, and that'll be just behind the wisdom tooth and on the edge of the bony portion of the hard palate. You don't want your thumb to slip back into the soft palate because that is extremely painful. And you can cause injury to the person. You don't want to slip back into this area here where the humulus is, the hamulus, which is a part of the sphenoid bone. It's just kind of hanging out there all by itself like a little antenna, and I don't know what it's for. But so we very carefully handle this particular spot.
John?
Yes, sir?
Is the hamulus part of the sphenoid or part of the palatine bone?
It's part of the sphenoid bone.
Really?
It's right next to the palatine. You have your pyramidal process of your palatine bone on the lower part of your lateral plate of the sphenoid, or the pterygoid plate of the sphenoid.
Well, looking at the suture here, it looks like the hamulus is coming off the pyramidal process.
It looks like it is, but it's not. It's part of the sphenoid. And if you look in all the literature, the hamulus is part of the sphenoid.
Oh, I see from this angle. Yeah, thank you.
Okay. Now, little tiny markings on these bones.
It's hard to figure where the suture is sometimes.
Yeah, we can sit and argue about where the suture is.
No, I just never knew that.
And the suture may vary from one person to another. The positioning of the suture will vary because of the of anatomical differences, which can vary widely. But basically, this particular greater palatine foramen right here, you start on the left side and hold this point right here. And then you go to the right side and hold this point right here. And now, what will oftentimes happen, and this did happen with Anna Voss after just doing some tailbone work, as a matter of fact, her one side of her upper palate was higher than the other. Is that correct, Anna? And that was tailbone work. Now, I've never seen that happen before. That's a first. But and so here you're working on a person's tailbone, and all of a sudden their palate's lopsided when they chew. That's a little inconvenient, but it shows how the various sutures become quite mobile. And I remember we had one lady, her sutures became so mobile that when she would put out a negative thought, her eyes would go like, watch me, her eyes would go like this asymmetrically. Her whole head would shift. She'd have to turn her thought back to positive, and her eyes would come back to normal positioning. And the whole bone structure just becomes like very moldable by thought. It was an instant thing, too. Doug, you'll remember that. Now, what will happen here is after we have taken care of the left side, then we take care of the right side. And we hold that particular thing there until that goes flat. It's going to take a while to do your palate work. And then you take your thumb or your finger and go back in here and hold that. And then you go very carefully along this particular suture, all the way across, and get all the calcifications out of that suture. Now, if there's been blows to the head or something like that, you'll have all kinds of different things that you'll come up with. Then begin back here on the very tip of the inner palatine suture and start moving up this direction and go all the way up through here and get all the calcifications you can out of that area. Yes, sir? Just a step at a time, find the pain and push. Now, sometimes you find some huge calcifications. You just stay with that, and after a while it becomes a burning inferno. Now, with the torus palatinus, where you have, like with Karen, you got quite a large lump here, you start where the pain is. You find the pain and push. Now, you'll find also, if this will be kind of exciting to you, okay, the spine in the back will have, this will be clear up on the cervical portion. First cervical will be right up here. You go right down this way, cervical, thoracic. You come down to this area here, and this will be where the where the lumbar, fifth lumbar right to here, and then this will be the sacral coccygeal area down through here. So if you have a problem, so let's say with the fifth lumbar, and you cannot get that lumbar taken care of by body electronics, you go in here and hold the point on the cruciate suture here, and that fifth lumbar problem will correct. We had one gentleman also on the sagittal suture, which goes from the soft spot, the anterior fontanelle, back to the posterior fontanelle here, the bregma and the lambda on your check sheets, which I hope you're studying. You'll have from here to here will be the entire spine. And so if you have a problem with your tailbone, oftentimes you'll have pain on the area just inside of the lambda or the posterior fontanelle on the suture here called the sagittal suture, which is between the left and right parietal bones here, okay? And so clear up in the front here on the soft spot begins, if you have a problem with your neck, okay, you then very carefully go along that sagittal suture and find any strange little lumps, bumps, holes, what have you, and you correspond that to a person's problems that they're having on their spine. Now let's say that you're in the trades, and let's say that you're a carpenter, and you raise your head up and you hit a 4x2 or a 6x2 right in the head, you know, and you're sitting there seeing stars for a while, and you end up with a bump on a certain part of your skull, which would correspond to the sagittal suture area right in here. Now, as you go down through there, all of a sudden you have pain in the middle of your back somewhere, and that pain just doesn't go away. And no matter how much body work you have on it, or how much Tom, have a seat, please. No matter how much body work you have done, no matter how much construction on your reconstruction with Rolfing or a whole lot of adjustments on it, everything keeps going out and the pain remains. You may have to treat the corresponding spot along the very top of the skull, and then the pain will go away in the spine. You got that down in your notes? Eric, Tarek, anything there, sir? No, sir. Are you sure? Yes, sir. Okay. But you check out where the painful spots are along along the sagittal suture here. Now, the same thing is true with the roof of the mouth on the palate. This will all correspond directly to the spine. If you have a problem with the hips and you're working back here on the palatine bone, this will correspond oftentimes to the entire pelvic area, both front and back, and this will correspond down to the sacral area, down to the tailbone. Yes, sir?
If we look at that suture there, and that corresponding to the hips, do we get a similar reflex from that occipitomastoid suture to the hips?
Yes, sir. That's correct. Okay, Wolf.
Go ahead, Wolf. Very quick question. Thank you very much. Can one press on the skull without doing the full cranial, if someone has got a back problem, for example?
Sometimes. That means sometimes it works and sometimes it doesn't work. But let's say that you have a hollow along your sagittal suture. It won't work. And therefore, what you have to do is to work this area out here, up and down in this area, and you find the whole top of your head will change structure, right up through here. Yes, just pops it up on the inside.
No, go ahead.
If you've done or had it if you've had like the spinal calcifications disappear, could they come back if you haven't done the cranial?
Yes, that's the whole thing. If you have a spinal calcification, and if you haven't had a cranial to work that out, then that spinal calcification will come back again. That's right.
A thing to consider.
Tom.
Just on that question.
Yes.
A thing to consider is that you're dealing with a hologram. Donna, you're dealing with a hologram where all the information from the entire hologram is still in any one part of the hologram. And so a lot of times you have a spinal done and you dissolve a calcification maybe virtually all of the way, but there's still a bit left. And basically, if the individual has not completely overcome the resistances that were locked into that calcification, then there's going to be enough resistance remaining that the individual is going to gradually attract certain experiences back into their life. They're going to resist those experiences, and over time the calcification is going to build right back up. So it's, don't look at this just physically like, yeah, the calcification can come back if you didn't do your cranial, because what it really comes down to is the calcification will come back if you haven't changed consciousness completely. I mean, that's really what's going on.
Yeah, I appreciate that too, but I was also wondering if, because I knew there'd been a lot of forceps delivery in that, if that may have needed to be taken care of. Because when I had the burning up my spine, I never had anything in the skull at all.
Now, just a moment, please. Ken, just a minute. In dealing with the nose structure also, right from the top of your nasal bone down to where you have your soft part on the end here, but on the bony structure, that will have a one-to-one correspondence with the entire spine also. So if you break your nose, and then you wonder why, after you break your nose, why you have back problems, there's a one-to-one correspondence here also. So that's why it's very important to get that nose job taken care of. Sir?
I figured Ken and I would talk back and forth now. This is concerning somebody who's on a nutritional program and is having his points held and everything else. I've noticed that as we've worked up further, I've had my points fire up, like where Kyle the other day was on 2 of them, and Sakara up my upper back and my lower back. When we're done and going into cranials or mastoids, the rest of them start to fire up. And I've had, pain and electricity in my lower extremities, which we've been working on, and we're not even touching those areas. Now, nutritional supplements, you're saturated, you're on the program, and you start working the mouth, the last part. Can this fire up the kundalini to come up through the spine, burn the rest of the stuff off, and kind of like the finishing touch to torch the rest of the body and facilitate healing?
The answer here is, Tom, there's an individual differences here that we have to deal with. Now, for example, I remember in Lafayette, Indiana, we had 9 people in a room after a seminar one night discussing different points. We had a lady yoga teacher who was in her late 50s at that time, and she was all calcified up and just in terribly arthritic condition. We worked. I was just praying away, wondering what in the dickens can I do for this lady, and I reached over without knowing what I was doing. And I grabbed hold of her medulla on her left big toe, and then I grabbed hold of the calf muscle on her left calf muscle, and I held them. And suddenly she was lit up like a torch and burning away. And she started down in her feet, which are terribly calcified, and her ankles that were calcified. And those, just both of them burned. And then it went right up the legs into the hip, and her calcified hip was burning. And then it went to the tailbone. And it burned gradually, one vertebrae at a time, going right up the tailbone. And it kept going all the way up to the first thoracic, and then this burning went up her arms. Now she had on the knuckles of every finger was a huge calcification like marbles. And she held her hands up just beautifully, just held them just going back and forth like this. And we watched her hands become like a 17-year-old girl's hands. All the calcification disappeared in the hands. Then the fire came back down to the first thoracic and went right up the skull and went right on out the top. And all of a sudden, she no longer had any resentment to her husband for not following her around on the seminar circuits. Because here she was a yoga teacher, and she was always interested in alternative things, and she was going from seminar to seminar, and her husband stayed home and worked. Now, her husband loved her dearly and had no animosity toward her at all. He was just a gemstone. But she resented the hell out of him because he wouldn't come with her to the seminars. And he stayed home and worked so she could go to the seminars. And when she understood that, her heart and anger melted completely toward her husband. She let go of all of that resistance, and she went home, and for many, many years, she was resentful toward her husband, and that resentment was totally and completely gone, and so was her arthritis. And so was the calcifications up and down through her spine, which were like large golf balls. Now, this is it. This is just simply the medulla point and the calf muscle. Now, that was for her. That may not be for somebody else.
Yeah, I think I answered my own question on that. It's like what you were saying earlier. I think Peter brought it up, which is anything can cause anything, and anything's going to cure it. I just thought that might be the last little niche there. Basically, this was for Lewis because I was thinking if we hit him with the supplements he's on and worked his palate like that, that guy'd light up and his spine just go be right up there.
Maybe, but he's not ready for a cranial yet because he hasn't got the nerve supply down through the spine yet, and we're working that down is just one step at a time, making sure he doesn't go into too severe healing crisis.
Wouldn't want to see that to happen to Lewis.
Where's Tariq? Sir, would you go over behind Lewis for a moment? Now, I want you to see if you see what I see. Lewis, would you take your left arm and swing that back up behind your head? Now, Tariq, what do you notice?
Well, I noticed that it's getting much more than usual.
What do you mean much more than usual?
Well, normally, the way I know Louis, he could reach just, let's say, about this area, and now he can reach easily under his neck, let's say.
Okay. Can you come up here and just briefly communicate that for the tape? But it seems to me like we're getting greater flexibility in the arm and more rapid motion in the arm. And I want you to just tell us what you happen to see in the matter.
Good morning. What I've seen in Lewis, as John checked it yesterday, is that he has a much deeper sense of notion. He could before reach, let's say, up to here, and now he can just easily swing his arm and reach basically down here. Because
could he reach the top of his head before easily?
Not very easily. I mean, he would
put your hand on top of your head, Lewis.
He would always, let's say, lean forward to clear his throat or backwards, and usually with that he would move his arm. But to me, there's definitely a depth got in there that he can reach somewhere down here in his neck.
There's more motion there, as I see it from when he first came to the seminar. Of course, I haven't seen him, say, in the last 4 years, so I can have something to measure by. Doug, what do you see, sir?
Oh, I've known Louis for about 2.5 years, and I've seen all sorts of changes in his mobility in the body. When I met him, which was August of '93, he had, my impression of him really was that he was really pretty much only from about here up. He didn't really have, he had very, very little motion in the upper body, and I think the arms and hands didn't work as well either. And mainly it was just like he had good, relatively decent range of motion in the neck. And I've just watched him sort of come alive further and further and further down the body. One thing I remember in particular was when we were at a seminar. I think this was true both times out at the Clays, wasn't it? We did a seminar out in the San Francisco area, and there was we had a little ramp that wasn't any steeper than these ramps. Maybe just a tad steeper, but we had this little ramp that we built to get Louis, just to get Louis in and out of the home. And one of the things I remember back then was that when you took Louis, when Louis went up and down the ramp, so he didn't get his head jerked around and all that, somebody basically had to stand behind him. And I remember doing that quite a bit, where I would just kind of get right behind him and just kind of lean in with my chest so that the back of his head was against my chest, so he wasn't getting whipped around. And I watch Louis go up and down these ramps now, and it seems like he doesn't need that anymore. It seems like even in the neck itself and the upper body, there's way more control. There's more strength and so forth. Is that what? Yeah.
That's correct. And if we just take that and move down an inch at a time and get the feeling down, because he has feeling now down toward the middle of the back.
And the upper torso, a lot of the muscles front and back in the upper torso are starting to come back, and Louis can do a lot of this sort of thing, going to the side and going front and back, much more than when I first met him, and really probably quite a bit more than even say a year and a half ago when Janine and Sama met him. You can see quite a difference. Janine and Sama have known Louis since about July of '94, so about a year and a half. And anything you wanted to say? Sama?
I actually remember when I used to assist him into his wheelchair, that the idea about his neck, I always had to support his back, and that's very, very true.
And that's a year and a half ago?
Yes, that was a year and a half ago.
We'll continue on with all that. Ken?
I'd like to get some clarification on the maxillopalatine suture. It's not completely clear. It goes straight across the left.
The maxillopalatine suture starts here and goes all the way across through here and back over to here.
Now that affects the hips, you said. Is that
this will affect, right here is right where you have your fifth lumbar joining the sacrum, which is a crucial area in all of your body work. We know that. Now that goes all the way into the structures of the hips. Now if you have a problem in here, this goes all the way through the hip area. And this one side of the left side of the palate would go to the left side of the hips. The right side of the palate goes to the right side of the hips.
So that suture would affect the sutures in the hips?
I would say it would affect all that whole area. Yes, sir.
Thank you.
Okay, any other questions? Okay, so
when we refer to that, working on that suture for the hips, would some of the work be done by the actual point before we get onto the suture, or would most of the hips relate to that?
I don't know again, David. Let me tell you something. I worked with the lordosis, where you have your lower back, your sway back. And I have worked and worked and worked and couldn't get that thing to budge one bit. We give a cranial. 20 minutes after we're into the cranial, the entire spine straightens out. Now, the thing is how did I know that? I didn't. But you keep working with it and put all of the tumblers of the lock in order, and after a while the lock opens. But we don't know whether it's going to be a spot on the top of the head. We don't know whether it's going to be a spot in the spine. We don't know whether it's going to be a spot in the cranial work there along the palate. We don't know if it's a triple axis concept. We don't know. But all of a sudden, the lock opens and things start happening. And so we we have to first of all identify all of the possibilities that are within our awareness. And once we've identified all those tumblers in the lock, then we start putting them in order. And eventually, when all the tumblers are in line, boom, you have miracles happen. Okay, sir?
Okay. While I'm up here, though, one little point I didn't get up and say, and I thought I should, so I will now. When we were talking about the pulsation through the body, now, I've had that happen to me fairly early on when I started in body electronics. And some of us, we've all got mixed up ideas, but some of us get something in our head that somebody says, and we tend to hang on to that. And I think we have to try not to do that. We've got to diversify, which is what has just been said in relation to the points. And some of us may be thinking, I could be doing you all a gross injustice, but some of you may have the feeling that that movement, that pulsation, relates very much to a physical change, as in the case of Anna and other people. But in my case, I've had it several times now, and it's been amazingly traumatic. But I haven't actually noticed any great change in me. I mean, I'm not too thorough about me, so I might have missed it. But on every occasion, the effect on my capacity to deal with myself on a mental level and so relate to other people has been tremendous. So all I'm trying to get across is, in my limited experience, it can have a very strong mental change within you. So, if something doesn't move, maybe something's moved up here. And sometimes that mental change doesn't hit you right between the eyes. It takes a little while to work. But something is happening, and they're good. They're good.
The external part of our body is all we see. We don't know what's going on inside. And when we change our thinking, all of a sudden our physical body starts going through tremendous physical changes. And it's not necessarily all mental. It's a physical thing, and it's just through the emotional body that has been transmuted. Then we go to the mental body, and we get the vibration of regeneration. And that can become quite disastrous to us because our whole universe goes through very rapid changes. Our job situations, our living situations, our relationship situations, and so on. All of a sudden, our whole life is in a nothing but shambles, just like two gigantic hands take us and twist us and move us off in a different direction than we've ever been before. And that's the way it is. Kyle?
Just two things. First one is there's a blood supply out to every cell in the body, sometimes indirectly by a diffusion process, sometimes quite directly. And if you're not feeling that pulsation through your whole body the whole time, then as I understand it, that will qualify as a level of unconsciousness or a level of numbness, because the pulsation is there all the time. It's just a matter of feeling it. Otherwise, those cells must not have a blood supply. That's just how I see it, and the conclusion I've reached from sitting watching this pulsing for about 4 years. I've always had pulsing from body electronics, every single time, and usually starts just as a person stops resisting, then I feel pulsation come through on the point. Also, every single, right down to the smallest level deep inside the cells, is in continual vibration. And these vibrations are through the whole body all the time. Every single part of the body is continually in a motion of one kind or another. And if you don't feel that, then that will also qualify as a certain level of unconsciousness, to my understanding. The other question I had was about the use of the headstand in changing the cranium, if you had any experience with that.
On the headstand, you're putting tremendous pressure on the sagittal suture and the parietal bones, and this creates, again, because of the interlocking situations there, will create pain in that area. And then that pain sometimes will spread throughout the whole head, and the person can't do their headstand. But yet, when this is done appropriately with the understanding that we're here to overcome these painful situations in these various yogic exercises, then we'll understand the purpose of it. We'll get more into that aspect of in the advanced procedures, okay? Now, would you all take out, I believe it's page 43 and 44. Page 43. Do you have 43 in your folders? And somehow whoever collated that is incorrect. Take that to Christabel and have that replaced. Okay? Sama.
Yeah, sometimes I was just wondering that with the size of my finger, how can I do a triple axis on a 6-year-old child if I...
With great difficulty. And that's when you have to start using your reasoning and find out what can you use. And you usually use another smaller finger from the mother and then show her exactly what to do.
We had a 4-year-old girl with cerebral palsy in one of the instructor courses, and she had a complete cranial done, including the triple axis. And my sister actually did the triple axis on her, and she used her little pinky finger. And my sister's fingers are probably at least as large as mine, and it was a 4-year-old, and it worked really quite well. So you just have to, use a little sense there, that's all.
Okay, let's take out page 43, if you would, please. Now, for example, if you look on the upper row of teeth, where it says T1, do you see that? And that's in the front teeth in the front. And we're dealing with the just one side where you'll find that there's going to be about 8 teeth on the upper left side, and there'll be 8 teeth on the upper right side, or 16 teeth in the alveolar arch on the maxilla. You got that? Okay, look at where it says T1. That goes to the coronary, to the neck flexors and extensors. Now, on T2, that goes to the myocardial, the vascular, and is connected again to the subscapularis muscle, which we won't get into here. But what I'm trying to point out is that in body electronics, when we're dealing with the cranial work, and you have a problem with a tooth, like a front tooth, you can go in with your thumb, as I'm doing here, Can you all see? Get in a position where you can see. And you put that right on the roof of your mouth behind the tooth. And sometimes you will find those extremely painful, and you'll work those out. My teeth in the front, both uppers and lowers, years ago used to be very crooked, about 1980. And I began working with my thumb behind each of the teeth, and my teeth rotated, bled very heavily, rotated very painfully, and then became straight. Okay? And this became quite exciting to me because I realized that that can be done for other people too. It is not without pain, because you're dealing with a whole lot of genetic stuff because you have inherited your teeth oftentimes from your ancestors. But the thing is you can work these areas out, and if you have a problem, for example, in your heart area, then you have problems with your four front teeth, then sometimes by working those problems out, this corrects the problem in the heart area. If you've had tooth extractions with tremendous Novocaine, and the Novocaine has never removed from that area and has been numb ever since, or you have mercury amalgam fillings in the teeth where you have your mercury tattoos in that area, which again numbs that area, goes down, numbs all the nerves, then that is going to have a direct reflex upon the heart area, which could be the same for any other tooth in the entire head structure. Is that correct? Do you understand this? Yes, sir.
I assume that where people have false teeth, you just work on the gums where the teeth used to be, behind where the
tooth was extracted? Yes, anywhere on that gum line, and work on that. And oftentimes the triple axis that you deal with, all of a sudden you're right into tooth extractions. Now it may take, you have to understand the healing crisis aspect. You have to understand what kind of pain level is the person willing to endure. And they may only be willing to endure, say, 10% pain on a scale of 0 to 100. And so if they can only endure 10% on a scale of 1 to 100, then they're not going to be getting into the traumas that will be like at tooth extractions and so on, where you're actually dealing with bone. That's heavy-duty extraction. That's surgery. And that might be at level 40 or 50. And so it may take 2 or 3 years to build up the ability to handle pain. You with me on this? Can you hear me on this? It may take a few years before you can handle pain at a level of 40 and 50, and suddenly there you're lying in bed one night and you feel your tooth being jerked out by the roots, because you're up to that level of pain where you can handle that. Now, a lot of people who have blocked off pain are down maybe at 5% level of pain tolerance. They can't handle pain. They think they're handling it when they're simply blocking it off, and therefore they have to work heartily at learning how to handle pain rather than just saying they're handling it by blocking it off, which is detrimental to their progress. Any question on that? Okay. Let me give you a little illustration. Let's look at the lower teeth. Okay, and let's say that a man is having a prostate problem, or a woman is having a problem with her uterus. And so you're down here, number L5. You see that on the tooth chart there? That's the lower tooth in the front. Do you see that? Okay, that according to this chart, and you'll have different charts with different interpretations by the man who writes the chart. This would be L5, where it says prostate, uterus, and here you have your piriformis muscle. We've talked about the piriformis muscle, haven't we not? On how a person cannot sit cross-legged if the piriformis muscle is in spasm, which goes directly to the prostate and to the uterus. And so you have your adductors and your gluteus medius, which is right under the gluteus maximus, below I should say. And all these are going to be connected right into L5. So if you have a problem with that area, and you have a prostate uterus problem, fibroid tumors in the uterus and this sort of a thing, you start checking that particular tooth factor, which will affect a certain meridian, and that will help to solve that problem. Now, down in Sydney, there are doctors now who are dealing with the cancer of the breast, and they're finding that certain teeth are directly related to cancer of the breast, and when that tooth is corrected in its root canal, is corrected on its mercury amalgam felling and so on, then suddenly that symptom disappears in the woman who has that particular problem. Are you with me on this? Okay, so there's a lot of learning that can be done in this area. If a person has a kidney problem, where's Rex? Okay, you see where it says kidney there on T12, T11? Now we know that the thoracic 12th and thoracic 11th vertebrae also go to the kidneys. I would also put down the 9th, 10th, 11th, 12th going to the kidneys, okay? But it's tied into the wisdom tooth on that lower area. Now, if we have an impacted wisdom tooth giving a serious problem, where it may be even infected or abscessed, then if that particular tooth isn't handled properly, you can have some very serious kidney disease. Now, once those are jerked out, then you might have more serious problems because of the blocking of the pain that's there through the tooth extraction itself and through the anesthetic, which sets it in there really good to where the person cannot feel the pain at all. And so a person says, well, I don't feel any pain in there. The dentist took good care of me. He took my tooth out. I don't feel a thing. And then 20 years later, you start having, on a good vegetarian diet or a lot of fresh and raw food, suddenly you start having pain in your teeth and wonder where it all came from, especially back in the wisdom teeth extractions. And then with cranial work, all of a sudden you're back there going through the dental chair with the extractions, and it's wild. Any question? Sama?
I've just realized now that my T9 and T10 were extracted about 20 years ago. And I think one of the greatest problems I've had is my adrenal problem. I've had a bridge over those places. I had a bridge after about 10 years. So the bridge has been on for almost 11 years now. Do you think the bridge can be of any use as far as these reflexes are concerned?
I think they all can be reflexed. Even with the bridge there, because you have, usually in a bridge you have dissimilar metals. And that's going to have an effect through the entire body because of the electrical currents that will be set up in those areas, which will then hit the meridians that are related to those nerves, and you can have a problem from that. So if you have two dissimilar metals in the mouth, that will definitely cause a problem in those areas where those dissimilar metals are found.
Yeah, I remember when I was trying to remove my amalgam fillings, some of them, and the bridge, there's the electric, I don't know how you use it, but an electric, this thing was used to measure the current on the bridge, and the guy just told me it was far more than I should tolerate in my mouth, but there's nothing, I couldn't think of anything to do. So maybe I was better off without having the bridge and having the place empty.
It may be so.
Thank you.
And that's where we start letting go of our vanity. I have some nice little dental pieces sitting in my briefcase because I can't use them right at the present time. And so when I smile at people, I sometimes scare them because I don't have any teeth in certain places. And we just have to let go of our vanity and do what we have to do and get that all taken care of. Okay, in time. It's nice to have some teeth you can chew with. Okay, now, anyway, I hope this tooth chart helps you. You can spend hours looking at this, then looking at the iris of the eye with all the various reflex angles to the body. Look at the tooth, for example, with the liver, and take that liver reflex and take that right on over to the breast area, and so on. And you can have a problem in the thyroid area, and then check the muscle structures out that may have been damaged. There's so many areas to look at here that'll take hours and hours and hours of study on your part. And you just have to go through that very carefully. Yes, Donna?
Which of the teeth on the chart are like the incisors, the pointy teeth?
Which ones do you want? Oh, the dog teeth? That would be the third, like L3 and T3. Okay? The next thing would be on the temporal sphenoidal reflex points, which is on number 44. And you find the same things as tied in with the teeth. You take a look at this page 44 and go through that extremely carefully, and you'll have points along the sphenoidal temporal lines up through there, and this is a whole another ball of wax. Now notice where this author puts these particular points on 44. It'll be different on one of the other charts that are in there because some of the other charts are right on the sutures themselves. But these are points on the bones that he has found that are particular significant to him, And I think that is important, wherein one author will find certain things will happen with certain points. Another author will find out the same things will happen with different points, and they're both right. So it's not a matter of arguing as to which chart is correct. It's recognizing that anything can cause anything in this particular area. Doug?
Well, it's the same thing with all the different charts. You're going to have a lot of different reflexes, and one thing reflexes to the next, and so nobody's going to agree 100%. But as John's saying here, the bottom line is everything can reflex to everything potentially.
To the continuation of our cranial work, we want to deal this morning with what we call the deviated septum. And we're not going to do what we call a nose job here, but we'd like to show you basically what we would do. Bob, could I have you just sit up here with a chair, please? We use you for an example. Just sit down straight ahead. Now, Doug, could you hold this for me, please? Or here, yeah, just hold this for me. Take your glasses off, please, Bob. Okay, in dealing with the deviated septum, if you take a good close look at your charts, you already have those in your package, so those you are expected to study, learn the anatomy, and learn where the sutures are. But if we have had a broken nose, Gloria, can you see from where you are? Okay, Bob, scoot forward just a little bit, please. Okay. Neville, can you're there now. Okay. When you're taking the break that a person has had in his... What's going on with your head? Your head is snapping. I guess that's to be expected. Okay. Get the tailbone done. That turns everything loose upstairs. Okay.
I just get the other one.
Thank you. Now, on dealing with this nose job, what we do is we take and begin working from right at the very top of the nasal bones. And we simply take and we pinch the area where the nasal bones are, and we hold that. And after a while, you'll get a lot of numbness, you'll get a lot of burning, you'll get a lot of pain. But you press and press evenly on both sides of the nasal bone so that the pressure is the same on both sides. Okay, you got that? Now, you take and slowly move down, and you may have to come clear out into the area of the zygomatic bone and put pressure on that also, because you have the nasal bones will have their sutures coming down on each side of the nose itself. You follow me on that? Okay? And so you may be clear out on the zygomatic bone structure, and then you may be in a little further and find out where the pains are, find out where the calcifications are, find out where the breaks are, and you find the pain and push, or find out where the calcifications are, and find the calcifications and push. Is there any question on that? You start from the top down. Now, if you have nothing at the top, then you start, you have the nasal bones ending right about in here, and then you come down into the soft portion of it, okay? And so you're dealing here now with the bone structures, because these bones are the part that have been moved and calcified out of position, causing the deviated septum. That's why surgically you have to go in and drill out all of the bone that has been displaced by the injury, and this is wherein it's a very painful and oftentimes incomplete type of surgery, because you're adding insult to the original injury. by doing any type of surgery on it. Yes, sir. After a cranial has happened, because, see, if you have a deviated septum due to a vomer problem, it may take 3 cranials or possibly even 4 cranials to get that vomer corrected and get that vomer back up in position, which has caused that nose to be twisted one way or the other. And if there's an asymmetrical condition in the skull, that'll cause the nose to be off at an angle, which can also cause a person to have an obstruction to the airflow within the nasal passages. You got me on that? Okay, so we just very gently hold the area here, find the pain and push, and we wait until everything comes into a perfect symmetry. Now, during that time, all of the trauma that has been, shall we say, recorded in that organic computer chip full of stored memory there, the calcification, all of that will come out to be re-experienced. Rex? If you have the fleshy portion, sometimes you have to hold the fleshy portion separate from the bone structure to get the trauma out of that, so that in turn will have the scar tissue dissolved and the condition will return to symmetry. Okay? Any questions here now? Is this clear? Who said no? Okay. Simone? Say that again.
Are you starting right between the eyes?
Are you starting between the eyes? We're starting at the top of the nasal bone, which will be right at the top of the bridge of the nose. Okay, you've got that on your anatomy, and you start up in there. Sometimes you have to hold right at the very top, because even these nasal bones here have been displaced from the frontal bone. Okay? But you have to find out where the ridges are, where the calcifications are, and then that'll save a person a lot of pain and trauma by going in for surgery. If after car surgery they insert the plastic, if the part of the nose has been redone in plastic, it's very difficult to undo what the surgeons have done. Because, see, the surgeons feel that they're putting the plastic in because there is no other solution for it. Now, once the plastic is surgically removed, then the bone structure can grow back and restructure again when the person is willing to have it happen. Now, the point of it all is, I am not going to make a decision for what to do, because once a person has had surgery, it's difficult to correct that surgery. If there has been a plastic part or a metal part, like hip surgery and so on, put in there. Now, the best thing to understand is that the body may reject something which is artificial if the body will regrow that part. But the thing is, what are you going to do with, say, plastic valves in the heart? What are you going to do with plastic parts in the head or metal plates in the head and things like this? The damage has already been done to a great degree. And it's going to take a Herculean effort on the part of the individual to make adjustments and changes in that. So I wouldn't make an issue out of it. We have a horse that we're riding, and that horse has been patched up here and there. Let's just enjoy it as it is and not make an issue out of some of these plastic parts that we've got in our systems. Bob, thank you very much, sir. Any questions on this deviated septum? Doug, anything you want to say, sir?
One of the things that I've had a little bit of experience with in a couple of cases is working in cranial work and also working right in and around the nose on people that have had like a lot of plastic surgery. I haven't seen much with. I don't think I've actually seen one where they had any extra bits put in there, plastic or otherwise. But I've seen a number of people that have had nose jobs, and I did a cranial in one particular case on this one lady that had something like 5 or 6 nose jobs. I mean, something really ridiculous, because every time she had it done, she wasn't happy. And it was really virtually impossible to get through all of that, because there was so much trauma locked in there and so much numbness from all the surgeries that it's really it can be a pretty colossal job sometimes for some people, because it's like when you've had a lot of the plastic surgery, they've cut bits out, but they actually have to break the bones. You know, they're surgically breaking a lot of the bones, and of course that's all done under general anesthesia. So you can imagine the degree of trauma that's going to be locked in there. It's going to be at a very, very high level of pain for people. So you have to be, if you're in that sort of situation, or you're working with somebody in that sort of situation, you have to be very, very patient and realize that in some cases it might take a long time and a lot of point holding before the person's going to be able to go back through that high level of trauma.
Let's take a look now. Pardon me? Okay. Go ahead.
Well, basically, in the inside your nose, you have the division between the 2 nostrils, which will include the fleshy tissue as well as the bone and cartilage structure. But it's basically, the dividing line between your two nostrils. And you'll find in a lot of people it's pushed over to one side or the other, which means you don't have much airflow. And a lot of you, if you just try a little experiment of kind of like blocking off one nostril and breathing through the other, and then switching and going back and forth a bit, I think probably quite a few of you here will find that you've got a lot of obstructions in one nostril or the other, where you may find to your surprise that you're doing probably 80 or 90% of your breathing through one nostril in many cases. Some cases almost 100%.
Okay, I'd just like you to just look at this one more time. As you're looking at this particular area, of course, you have your thumb working down through here at different points, or your forefinger. This would be the left side as you take and twist the cranial around, and this, of course, will be the right side. Now, what we want to consider is a 1-to-1 mapping of the palate, the hard palate, to the cranium itself. Now, for example, Gloria, could I have you up here, please, just a moment? She's only had half of a, and there's a little bit of a asymmetrical look right now. But let's assume that Gloria, in her younger years, has been mistreated physically and has been pounded around a lot and has a lot of solid blows to the head, some of them which would leave fractures to the skull, or shall we say dents resulting from the trauma to the skull itself. Let's say that we have a right frontal damage. Now, just have a seat here for just a minute, if you would. Here, Gloria. Okay, right frontal damage. We would then go, excuse me please, thank you. We would then go to the right side toward the front of the palate, and we'd go right in through here, and we'd try to find out where the injury would be, recognizing this as the midline, or the sagittal portion. Okay, now we would normally find a little calcification in this area, and we'd hold that particular calcification with either our finger or our thumb. And what would then happen, okay, and you have to be very careful with this, what would then happen is, as you're pressing on this, the person will re-experience the blow that they had to the right frontal portion of their skull, and you'll find that that bump will come out. Okay, and that'll straighten out that particular problem. And we've had people, for example, that have had migraine headaches after an injury to a certain part of their skull, and they've had migraine headaches for years. And by working on the cranial portion of that, like if they had a bump here, you work up here somewhere and find out where the spot is, where the pain is, work that out, the bump goes away, the migraine headaches go away. And sometimes it'll be with the thought pattern, my head will never stop hurting. My head will never stop hurting. And just a thought pattern like that will hold the migraine headache in place. So we have to be very aware of the thought patterns associated with any type of a cranial injury. If, for example, now here with Gloria, have a seat here. If we have a problem on the sagittal suture itself, now we discussed this a little bit yesterday, and we have any bumps along the sagittal suture, we will go in and realize that the area from the incisor, what we call the incisive foramen, from here on back to the tailbone here, all of this will go from the first cervical vertebrae all the way back. And so we come along here and try to find out where the little lump will be, which will cause the problem in the head structure on top, which will have a direct reflex to the spine. So therefore, if we have a problem with this portion of the, shall we say, the torus palatinus, where the vomer comes down, then oftentimes we will have a chronic condition of, shall we say, an inflexibility of the spine, or perhaps we'll have a scoliosis of one type or another, which will affect our ability to function normally, because our spine always seems to be not quite correct. Now, we can work on the spine till doomsday, and it's not going to correct the torus palatinus. It may not correct the thing up here, but the cranial work eventually will, under tremendous pressure that we have to hold on that particular situation. So that will be something else that we have to consider. If we have a blow to, shall we say, the left side of the head, like in the temporal area here. Now, of course, the temporal work that we do, temporal bone on the mastoid process, this may help to solve it. But if it is a specific indentation or a specific break that we've had here, we would go then to the left side, somewhere down in here, and work that particular area out. Down in this area, on the left side. Now, there are several of you who had the most beautiful experience of having the pain across the hips, where you worked, as you worked from across here on the right side and over here onto the left side, you found the pain would happen in your hip area and pelvis area, right as we continued working on the blockages and the pain back in through here. I'd just like to be interested. May I see a show of hands of those that felt that pain and heat through the pelvic area as the cranial work was done on the palate? May I see a show of hands? Several of you told me that had happened. They're gone. Okay. And so that already happened. Okay, but that's one thing that was really wonderful. Now, basically, that one-to-one mapping in your notes, please consider that when you're exploring the cranium there. Thank you very much, Gloria. Appreciate that. Now, that's important, that one-to-one mapping. So we did need to talk about that. Now, next thing, there's a lot of books up here that I hope you come up and get the addresses for these books and so on, because these books will be invaluable for your library. You got months and months of study. Years? Okay. One of the things that you're going to find very difficult, as an instructor, as you go out and start teaching people, is people will want all of the intellectual information you can give them without wanting to have the experiential portion of this. There is no possible way that you can intellectually explain body electronics. There is no possible way that you can explain cranial electronics to a person intellectually. Therefore, be on your guard and do not allow anyone to be trained who hasn't had that intellectual experience to where they know from their own experience what another person goes through. And everyone will go through this a little different. But what I've written down here is one has no business representing a work such as cranial electronics unless he has personally experienced the work himself. Now, one must first of all be able to receive this work in their own situation before one can give that to another person. A lot of people become, because they have not experienced the pain involved, they can never develop the compassion that another person, when they're going through their pain, you need that patience and compassion to just wait until they can go through their pain. And there's no way to explain that intellectually to a person who thinks a person should hurry up and get through it now, and they get upset because the other person isn't doing it right. Now, how can you tell a person, how can you judge if a person's in pain? How can you hurry up the pain? Now, you've all been there. You wait and wait until we can tolerate and eventually experience that pain. And sometimes we have ingrained within us a tremendous resistance toward going through that pain. And we just have to have compassion, we have to have patience, and we have to wait and not judge the person because they're resisting. My goodness sakes alive, that's what we're here for, is to help to relieve the resistance from people's circumstances, because we've all chained ourselves into a situation with invisible bars, with invisible chains in an invisible prison from which we cannot escape, because our resistances are here in each one of us, and I might add, well hidden. And so let's have just compassion, tremendous compassion and patience with people, realizing that each one of us is down here to help people release that resistance gradually as they're capable and willing to do so. You cannot hurry these processes up. Some of us have been working with problems that we've had, pain that we've had, genetic things that we've had for many, many years. And finally, after maybe 40 years, some of us have learned how to overcome a couple of things. And don't knock yourself out and shall we say, kick yourselves to pieces because you've been in this for a year or two and you're not perfect yet. Okay? It takes a long time to overcome eons and eons of resistances that all of us have deeply imbued within us. So that compassion and patience is not only for ourselves, but for other people. Now, what I'd like to have happen now, Doug, I'd like to have Doug give you a very in-depth discourse on a subject that is very pertinent for today, that we might be able to alleviate a lot of inconsistencies and a lot of false notions that is spread through propaganda, through the media, through the newspapers, through personal experiences. And I'd like to have Doug take the bull by the horns, and between the two of us, perhaps in the next hour or so, we will have opened up Pandora's box of questions and confusions and considerations that really need to have current day addressing on this matter. And so, Doug, if you talk about homosexuality and bring this about into a meaningful way, I'd be grateful. Yes, sir.
I just wanted to ask a question on the palate. If someone has a blow to the head, let's say I fall over here and hit my head on something really hard, or I injure my back, will the calcification or or will it show up directly on that line in the pellets, like instantly?
It may. It may, but remember it takes a while for a calcification to form with the nutritional substances or lack of them in an area where the trauma has occurred. It takes a while for a scar to form when an injury heals on the body. And the same thing with any other part of the body, like the calcification or lesion on the skull or on the sutures of the skull.
Thank you. The other question was, I've got a crooked tooth in the front which is like really crowded. You talked about holding the points either side and I guess at the root of the tooth on the gum here. So is that something you can do yourself?
It is something you can do yourself, but first of all, make sure we get the triple axis done, which will oftentimes change the exact structure of the jawbone, leaving room for the crowded teeth to open up and then fill in the spaces. Okay. Yes, sir. Well, let's say you already have the suppressed thought. Come on up here. Just make room for Speedball to come up here. Okay, come on up here, Louis, so that we can chat on the matter. Where's the other horn? Got it there. Okay.
My question is, as Ian just put it, asked if a calcification or lesion would come on immediately. And what I was wondering is if it doesn't come on immediately, if it takes a while to develop, is that because, as we talked earlier with the hologram, where if you have a piece of the hologram, every bit of that experience is in that piece. So if you resist an experience, you only remember a part of that experience, yet within that part you have the entire experience. Is that why the calcification or lesion takes a while to develop?
That's the way I see it there, Louis, yes. And likewise, this is why the physical body is what I consider to be the doorway to spirituality, because we have to take care of the physical body, dissolve those calcifications, that those imprisoned thoughts, feelings, and spoken words that are in that calcification can be re-experienced on the mental level. Because until we can experience on the mental level, that which exists on the physical level will still be bound to the physical. There's no way to get around it. But it's all done by the natural accretion, if I can use the word accrual, of material, of substances, creating a calcification in that area. Okay, sir? Does that help? Okay. Questions? Okay, where did Doug go? Until Doug gets back here, you notice how things begin to really work well when you're under stress, and especially in the area of lesbianism and gay activity. This has not been addressed thoroughly, and I'd like Doug now to give a scholarly presentation regarding this matter.
Okay, before I start that, I wanted to reiterate something John was saying there just a few minutes ago. If you're involved in body electronics, you can't possibly teach somebody else something that you don't really understand yourself, and you can't possibly understand any of this stuff if you don't experience it. So one of the most ridiculous things that we see in body electronics is people trying to teach who aren't even getting their own points held. This is completely absurd, and we see point holding groups being run by people that aren't getting their points held, and this is total nonsense. And it's not enough to say, well, yeah, I've had my points held. I did that a bunch 5 years ago. You got to keep doing it. You got to keep working on yourself, because the thing about this is everything keeps changing in body electronics. We hit new levels and new types of experiences, and the kinds of things that happen in point holding sessions today are different in a lot of ways from 4 or 5 years ago, let alone 10 or 15 years ago. So if you're not keeping up with it, you're just not state of the art anymore. I mean, if you're not continuing to get your own points held on a fairly frequent basis, you're really missing the boat. And as John says, you don't really have any business teaching, let alone trying to represent this. The phrase that comes to mind for me here is you can't lead where you haven't been or where you won't go yourself. So really all of you here, you need to keep doing what you're doing, which is getting your own points held on a very, very regular basis, because you've got no way of relating to the people that you're working with otherwise. And believe me, those of you, and I think anybody here who's had a few cranials will back me up on this. You think you remember how painful it was, you think you remember how painful it was, but I guarantee you, when you start another cranial, whether it's your second, your third, your fourth, or your 10th, you're going to find out that you don't really remember just how painful it was if you haven't done it in a while. So I would encourage all of you here, if you have any intention whatsoever of continuing on with this and teaching others, and whether it's in a point holding group or whether it's doing seminars, you have to keep working on yourself on a regular basis. Ian?
How often can you do cranials, and what's like the optimum amount of space between them or whatever?
I don't know if there's any rule of thumb for everybody, but I really feel like, especially after a first cranial, that you got to give yourself a little bit of time to adjust. I think for most people, if you've had a good thorough cranial, you don't really want to rush right out and do another one next month. But I think it would be an individual thing. Some people might need to wait quite a while, but I personally would recommend for most people that they think seriously about doing another cranial maybe 6 months down the line or something like that.
Agreed on that.
I think it would be premature maybe. Some people might be ready in 3 or 4 months, but I think you have to understand that your entire universe is going to change as a result of the cranial, and it takes a while for things to settle out, because you're not just affecting the crystals in the body, you're affecting the crystals in the entire universe.
In reference to what Doug has said, I hope you understand that as you begin to change your consciousness, and you're seeking with all of your heart to find the truth regarding the mysteries of the universe and the mysteries of the human mind, and bringing these all into subjection to the laws of universal, shall we say, the universal laws. As you do this, your entire conscience, your thinking will change, and then your emotional body will go through tremendous transformation, and then your physical body will go through tremendous transformation. And as all of a sudden, it will be like 2 gigantic hands will completely turn your life upside down. So all energies which will be kind of hanging on to you, holding you back from your progression. Now listen carefully. All energies of a personal nature, of a relationship nature, of an economic nature, of a social nature, of a religious nature, all of these things will just be turned literally upside down, and you'll be thrust off in a different direction, almost completely out of your control, and then it'll take a year or 2 to settle out from that. This is why we've oftentimes had people come through an instructor seminar, they have a cranial, they go home, and everything has completely changed, because the energy patterns that they have are no longer acceptable to the energy patterns of people that, that they left, just say, a month or 2 before. They go home and they have strangers meeting them, and you'll be a stranger to them in some cases. And it's going to take a lot of patience, a lot of perseverance, and a lot of compassion to continually work with this until those energies can be uplifted to meet your own situation. You follow me? But I'm going to promise you, upheavals will be of a very common nature.
The healing crises just get better, folks. I can certainly assure you of that. Esther? from personal experience, I can assure you the healing crises get bigger and better.
I'm glad Ian asked that question because it has been a question for different people. What I noticed with my first cranial is that it was like I woke up every day a new person with new environments in the same house and so on. And it kept going on. It kept changing. And when I thought about a cranial, what came into my mind was, if I have another cranial now, I mean, I might be going, it was as if I had not finished settling yet with the first cranial. So things were opening. It is like you do the cranial, that's not all about it. It keeps going on. And it goes on and on and on until, but there is a danger where, when Doc said you hold courses and you don't have your points held often, I felt guilty about that because I've had people asking me to be on the table. But I was always like, I was in a continuous state of change. And it had to do with the cranial because, believe me, you are in a different world as well. So I just wanted to share that with you.
A lot of, I've heard John talk about this concept a number of times in the past with this idea of feeling like a giant pair of hands has just kind of picked you up and shook you real good to make sure nothing's still sticking to you and moving you, from one place to the next. And so I guess it's one thing to hear somebody talk about it and sort of think you understand it, and it's quite another thing to experience it firsthand. And it's there can be a lot of pain involved. All the emotions are really there for you, and it's quite an intense experience to go through. And I think one of the hardest things for any of us to do is to just let go of the past and just move on. And one of the things I would say is that if you ever find yourself in that sort of situation where you're really struggling with change, you're really struggling with the fact that your life is moving in some unexpected directions and changing quite rapidly before your eyes, and as John says, a tremendous amount of it will be beyond your control. I think one of the things that we have to all really work at is just letting go of how we want things to be, letting go of how we wish things would have been or could have been or should have been, and just accepting the fact that things are what they are. It's like Peter made the statement earlier on in the course that everything that ever was something to the effect that everything that ever was couldn't have been any way else. And I think we have to apply that to the present moment right now, that everything that is right now couldn't be any other way than it is. And what we each have to learn to do really is non-resist the moment that we find ourselves in and make our choices based upon what really is, rather than trying to make our choices based on what we wish things were. You all see what I'm saying? Because it's and I think most of us, I think I've done this a lot in the past, I think most of us try to make our choices based on what we wish was reality, rather than simply accepting what really is reality and acting accordingly.
I remember a fellow who was very, very critical of me, very upset with me, and he was upset with me for several years. Leroy?
Oh, yeah.
And finally Leroy came over. He says, John, I now understand. He says, I now understand because I find myself in exactly the same position you're in, and I understand. That's all he could say. He says, I now understand what you were trying to teach me all these years. And this is what we look at. We cannot judge what another person is individually going through, because it's all water will seek its own level. And the thing is, when that water seeks its own level, can you control where that water is going to settle out? There's no way. And so you just let it all happen and pick up the pieces and continue on.
I just said, well said, Doc, because it makes me feel almost proud that you're my teacher. And your example is just all we need. Thanks a lot. Thank you very much indeed.
Okay, on to something else. Okay. I guess we're going to start talking about some other resistances. Thank you. You usually do. Okay. John's asked me to spend a little bit of time this morning talking about the subject of homosexuality, and you gotta figure with body electronics is that when it really comes down to it, we're not real politically correct. If you haven't figured that out by now, I mean we got eyes changing color and skin changing color and all sorts of things. So you have to just. We live in an age where everything's bass-ackwards. We live in an age where most values and most concepts and most ideas about things are virtually 180 degrees apart from the truth. And as a result of that cultural conditioning in most societies, and as a result of the pressures from the media and everything else, there's certain issues that are very, very hard for people to look at as they really are. Obviously, a lot of people, when they first hear about body electronics and they start hearing about eyes changing color, immediately, John Ray's a bigot. I mean, that's an easy tag to slap on anybody that reports what you see. I mean, most of you here have seen eyes change color. So is John Ray a bigot, or is he just simply telling you what is? Is he telling you? I mean, is he basically reporting the news?
Just reporting the news, and that's the position you take.
And yet, in the past and perhaps in the present, when you report the news, sometimes you're not very popular. When you say things as they are, or as you've seen them, or as you've experienced them, this goes against a lot of political agendas. It goes a lot against social agendas, and it doesn't make you real popular. So for a lot of people here, just recognize that this is a subject that in this day and age, where we're basically in many countries we're on the verge of thought crime. We've gotten to that point in a lot of societies where you're not even allowed to say things, you're not even allowed to think things. Just recognize that there's a lot of pressure on people to stay away from the truth. So, anyways, this is how I've seen it over the years, and John will have a lot to add to this. First of all, you have in a human body a certain amount of resistance, a certain amount of electrical resistance, which is measured in what is called ohms, OHM, ohms. That's the unit of resistance, an ohm or OHM. And you can measure the amount of resistance in a human body with certain types of equipment, which is basically a galvanometer, where you're getting a resistance across the, you've maybe got like two, a thing that you're holding in one hand and a thing that you're holding in another hand, and it's, because the circuit's complete through your body, you're measuring, you get a very, very precise reading on the amount of resistance in the human body. Now, under normal circumstances, a female body will have approximately 5,000 ohms resistance. Under normal circumstances, a female body will have approximately 5,000 ohms resistance.
Can you hold your spot?
Sure thing.
Okay. I'd like to take a moment to try to explain the history of the human body as we know it. First of all, this did not evolve here upon this earth. many things did not evolve through evolutionary methods here upon this earth. If we were to plant a garden, we go down to the local store, the garden store, and we pick up seeds that were brought here possibly from Indiana or Ohio, or possibly from South America, possibly from Malaysia, and we plant them in the earth and we have a nice little garden. Or, the seeds can come from any part of the earth and plant it in our garden. Such as it is with planet Earth. The seeds, the plants, the animals themselves were brought from other planets and brought to this earth to propagate this particular earth. And this puts us into an interesting situation to explain why you cannot really have a clear, defined evolutionary method of one plant from another or from one animal to another. But yet there is a basic carbon-hydrogen base which goes throughout this particular quadrant of the universe, where it's designed for the perfection of the soul. This physical body was designed and perfected to become an absolutely beautiful example of receptivity of all sensory experience and a transmitter of all mental activity. This body is absolutely beautifully designed by the gods. And the gods themselves came to this earth and propagated it originally. And these animals that we call human beings did not derive from the gorilla or from the monkey or from the ape. It didn't happen that way. We are descendants, literally, of those who were gods themselves and had the ability of propagating an absolutely perfect DNA pattern upon the earth that the souls of man may progress. Now, over a period of time, we digressed from law. We started killing each other, and we started having all kinds of pain that was suppressed in our bodies. And over millions of years, we can trace archaeological evidence back over 3 million years on this earth alone for inhabitation of the human beings. It's taken a long time for us to get into the condition we are. And advisably, it'll take a little while to change all that. But the thing we have to understand is that theory of evolution is absolutely false, but plants and animals and humans all came from other planets to propagate this particular earth. I want you just to think about that. Yes, sir.
I'm a bit confused. You just said the gods came on planet Earth and actually propagated planet Earth with man. And then you say the plants and the animals, and did you include man coming from other planets to propagate, or just the animals?
Say that again, sir.
I was just wondering, when plants and animals and other things were brought from other planets to propagate this earth.
Yes, sir.
Do you include man? Because I assume man came the direct descendants of God the Father on earth.
Okay. Just put this on a shelf and think about it, because this is the way it is. So just forgive me for being blatant here. You have a hierarchy of spiritual creation, and you have a temporal creation. And you'll find this well explained in the book of Genesis. Okay, you have your spiritual creation first, and then you'll have your temporal creation. If you study it and follow it through very carefully, you'll understand it. You have that which is called the Elohim, which is the council of gods. And you have one representative from the Elohim called the Elohim. And that is the office of the Creator. It is occupied by a being such as us. Now, the office of the Creator, or the office of God the Father, or we have the Holy Trinity, which Salma had a dream about last night. Correct, sir? And you have the Father, you have the Son, and you have the Holy Ghost. Now, you must understand that the office of the Father was occupied in the spiritual creation of this earth by a man called Elohim. Not the Elohim, which is the council of gods, when you get back into the ancient Jewish teachings. Now, you have a second person called Jehovah. You read Daniel chapter 7 very carefully, and you get into an awful lot of good information there. And Jehovah is in the office of Christ because Jehovah himself was of the bloodline of the Christs. Because Jehovah was a Christ on another world, not upon this earth. And therefore he himself was a resurrected being from another planet, as Elohim was. And then you have a third individual who is in the office of, think of the word office, of what we call witness and testator. Because in every organization, to have that as a perfect organization, you must have a council of three. So you have the council of three being occupied by God the Father, God the Son, and then God the Holy Ghost. And you have to understand also that the reason we call that God the Father, God the Son, is because we're dealing with masculine energy, we're dealing with creative energy, we're dealing with young energy, where the female version of this is always going to be represented hand in glove with the masculine energy. But the masculine energy, because of the creative force, this is what is recognized. Okay? But you do not have the male without the female throughout all eternity. Now, you have God, the witness and testator, who happens to be, if you study it very carefully, you have the archangel Michael. And he is in the office, in the spiritual creation of the witness and testator. Because it is Michael himself, who's a resurrected being from another planet, being an archangel, the chief of all angels. It is he himself who came down to this earth with a colony of gods, who fell to earth that man might be, because he took upon himself the substance of the earth and then gave reproductive means to man on this earth by having children born directly through his own loins and through woman who came down with man, as is spoken of by Eve, who came from his side from another world. That's where the whole mystery of the rib comes about. Because Eve herself, Phoebe, Lilith, and others all came down from another planet where there was a definite resurrected beings there, and they came here to populate this earth. And there was a colony of people that came to populate this earth with an absolutely perfect DNA. And that has occurred over many different times, where there has been an infusion of perfect DNA over millions and millions of years.
John, do you know the other planet that this other planet? Do you know the name of it?
Yes, I do.
You're not going to tell it right now, though.
I'll tell you.
Okay.
Might be the last chance I have to tell you.
All right. Thank you.
I told you I was going to unload on you. Okay. Here we have. When this particular planet goes through its baptism by water, it will also go through a period of time where it goes through its baptism by fire. And at that time, this terrestrial orb will become a flaming sun. And the people who are capable of enduring that energy, by increasing the energies, they will be able to endure, and this particular planet will become a sun, and we will be living on it. Hopefully, we will be living on it. This is where it says, the meek shall inherit the earth. Those people who cannot endure that tremendous energy that will take place during this transformation of the Kundalini fire, which will engulf the earth itself as our Mother Earth, because the dust of the earth, we are the dust of the earth. And as we continue to grow, Mother Earth will reflect exactly what we are doing in our consciousness change here upon this earth. And this earth will become a sun.
Am I correct that there are 3 orders of, don't you also have something called the you have the
Don't worry about that.
Okay.
Okay, what are we having? Tape change?